Hello and welcome. I'm Bianca, the CEO of Storm Skills Training CIC. We are pleased to be working once again with our colleagues from the Multicentre Study of Self-harm in England in a new series of webinars where we take the insights from this huge data set and the hard work of our clinical and academic colleagues, and we translate them into your work, your practice. Today, we're focusing on self-harm in older adults, a group who are often overlooked in the conversation about suicide and self-harm, even though the risks, particularly around suicide in those who have self-harm, can be significantly higher in later life. Today is about understanding what the research from the Multicentre Study of Self-harm can do to improve our practice and reduce the number of older people who take their lives. I'm delighted to introduce our presenters, Jenny Ness and Anita Patel. Jenny is the lead health services researcher and chief investigator for the Derby Monitoring Study of Self-harm, and Anita, the research project manager with Derbyshire Healthcare's Perinatal Community Mental Health Services. They bring you a wealth of knowledge and experience, and we are very pleased to have them share that with us today. You can learn more about them in their bios that are provided in the links below. I'd like to thank them both for sharing their time and experience with us today, and I'll hand over to you, Jenny. Thank you.
Thank you, Bianca, and the whole Storm team for another opportunity for collaboration. This feels like a really nice follow-on from the conference that we hosted together back in 2024. So as Bianca said, I'm going to share some findings with you from one of our multi-centre study of self-harm pieces of work, looking at self-harm specifically in older adults that come into the emergency department. And then Anita and I are going to have a conversation about what these findings, what we can take from these findings and apply to clinical practice, not just in the emergency department, but actually beyond that when we're looking at how best to support people in moments of distress. So today, when we're talking about self-harm, we're talking about any intentional act of self-poisoning or self-injury, irrespective of motivation. So within this study, we look at all presentations to the emergency department for self-harm, irrespective of whether that self-harm may have been part of emotional regulation for somebody or whether it may have been a suicide attempt. We take a holistic approach and include all of those presentations. So why are we talking about self-harm in the context of suicide prevention? Well, there is no bigger risk factor for future suicide than self-harm behaviour. So nothing predicts future behaviour better than previous behaviour. And research has found this time and time again. And actually one of our previous multi-centre studies found that people presenting to the emergency department following self-harm were actually 50 times more likely to go on to die by suicide than other members of the general population. So it's really important area for us to look at and group for us to look at when talking about how best to prevent suicide. And we can see this when we look at trends over time for suicide and for self-harm. So this is based on some multi-centre data, and you'll see that for both males and females, the rates of self-harm and suicide track each other, mirror each other over time, again, kind of showing that strong correlation and relationship between the two. So as a little bit of context around the multi-centre study of self-harm and what that is and where the data comes from. So it's a collaboration between 3 high-quality monitoring projects, so local monitoring projects, one in Oxford, Manchester, and then with ourselves in Derby. And we pull all that data, combine all that data together to give us a much more representative and larger data set on which to analyse and interrogate. So what do we collect? So we collect data on self-harm presentations by all people to the emergency department. So that's irrespective of whether they've been assessed or seen clinically. If they've walked through that door and spoken to someone at the reception desk, then we capture data on that presentation. But depending on how much clinical contact an individual has had when coming into the emergency department following self-harm determines how much information we can collect for that presentation. So for everybody that comes into the emergency department, we collect kind of what we call our core data, so demographic data, and then details around the act of self-harm itself, so what method was used, and the time and date. And then for those individuals who have received a psychosocial assessment by our liaison psychiatry services, for example, we're able to get a little bit more information around those presentations. So we've got some information on somebody's history, so previous self-harm, psychiatric history, and then onward referral. So what that presentation then led on to, was it a referral to alcohol services, for example? Was it back to primary care? And then we also have information around problems that precipitated the self-harm. So these may be ones that have been identified by the individual themselves or by an assessing clinician. So it can range from problems relating to relationships or finance, alcohol misuse, or mental health problems. And then we follow everybody up in terms of repeat self-harm. So if somebody comes back to the same centre again with self-harm, we capture information on that. And then we follow everybody up in terms of mortality, and we use data linkage through NHS England to give us information. So we know for everybody that comes into the emergency department with self-harm, if they were to go on to die by external causes, accidents or suicides, or by any natural cause, and what that cause may be. So I'll hand you over to Anita now, who can give you some more information on what we found through the project looking at older adults specifically.
Thanks, Jenny. So we'll now focus on self-harm in older adults, looking at some key research in this area before sharing our study findings. Numerous research studies have shown that self-harm is a significant risk factor for future suicide, but this association has been found to be particularly strong in older adults. Murphy and colleagues found that individuals who were 60 and over, who had self-harmed, were 67 times more likely to die by suicide than older adults in the general population. Now, this really is a stark statistic, but puts into perspective the importance of monitoring trends in self-harm because of the strong link between self-harm and suicide in older adults. Generally, older adults are an underrepresented group in self-harm research. Previous research has often compared younger age groups with the older adult population, with few studies focusing on older adults as a distinctive population. So there may be less recognition of self-harm as an immediate concern because prevalence of self-harm is lower in older adults than in other age groups. However, if we consider the risk of future suicide following self-harm for this group, then we require greater research focus on this population. Previous research has also identified some clear differences in the preceding life problems reported by older adults. For example, there were more physical health problems reported by this group that appears to precede self-harm. Repeat self-harm is lower than in other age groups. This could suggest that older adults are less likely to repeat self-harm. However, if we again consider the risk of future suicide in this population following self-harm, as well as the increased chance of mortality and morbidity, this may provide some explanation for the fewer repeat presentations to the emergency department. This also suggests that there may be fewer opportunities to intervene. A limitation within the research literature is that findings on clinical management and the application of NICE guidelines in the management of self-harm in older adults are limited. Understanding how this guidance is working in everyday practice may provide opportunities for future learning. So our sample of older adults from the Multicentre Study of Self-harm in England database comprised of individuals who were 60 and over. Our data ranged from 2003 to 2016. They were grouped by age, a younger group, those who were 60 to 74, and an older group, those who were 75 and over. We also looked at gender, comparing men and women. There were 3,850 self-harm presentations by 2,684 individuals. The number of men and women in the sample were fairly even. However, there were more in the younger group, 71%. and this younger group accounted for 76% of the self-harm presentations. Our analyses were adjusted to account for differences within the groups. We found a 34% increase in the rate of self-harm between 2008 and 2016 compared to the self-harm rate between 2000 and 2007 from a comparable study. Rates of self-harm also increased over time for men who were 60 to 74 years of age. This can be seen by the light blue line, which steepens particularly from 2012 onwards. While there was an upward trend in self-harm rates for women, this was not found to be significantly different over time. We also found a reversal with the gender ratio of self-harm, with self-harm being higher in men in the older group than in women of the same age. This aligns with previous research findings. We found differences when comparing the two age groups and between men and women. While self-poisoning was the most common method of self-harm, men were more likely to self-injure than women. 41% of individuals had a history of previous self-harm, with more women reporting previous self-harm than men. More men presented to hospital having consumed alcohol within 6 hours of self-harm. Women were more likely to have received prior psychiatric treatment than men. Those who were 75 and over were less likely to have been in receipt of psychiatric care at the time of self-harm than the younger group. The older group were also less likely to have been receiving support for their mental health from their GP. The study findings align with earlier research that distinct problems precede self-harm within the older adult population. Mental and physical health problems were the most frequently reported concerns that individuals faced at the time of self-harm. When looking at preceding life problems by gender, men reported more problems related to finance and alcohol. For women, more problems related to relationships with friends and family. Our findings, when grouped by age, showed that physical health problems were more likely to be reported by those in the older group than those in the younger group. The younger group reported a range of preceding life problems compared with the older group. This included problems with alcohol, finances, employment, and in their relationships with partners or friends. 2/3 of individuals received a psychosocial assessment following their presentation to the emergency department for self-harm. Following assessment, women were more likely to be referred for psychiatric outpatient treatment than men. Over 3/4 of individuals who received an assessment were admitted to a general hospital bed for medical treatment. More than 1 in 5 received onward referral for inpatient psychiatric treatment, with those in the older group more likely to receive this referral than those in the younger group. And those in the younger group were more likely to be referred to drug and alcohol services. Overall, 18% of individuals represented to the emergency department with self-harm during our study period. Over 1 in 10 represented to hospital with self-harm within 12 months of their index presentation. Those in the younger group were more likely to represent with self-harm. Some risk indicators for self-harm repetition included receiving current psychiatric treatment, which was a prominent risk indicator for both men, women, and those in the younger group. Previous self-harm was a risk indicator for men and the younger group. For men and those in the younger group, problems with alcohol were also strongly associated with self-harm repetition. Physical health problems were a significant risk indicator for those in the older group. So, the rate of self-harm appears to have increased within the older adult population. This suggests that there may be an increase in demand for health services from this population and points to it being an increasingly important area of focus within self-harm research, policy, and practice. Assessment really is key to enabling a person-centred approach in identifying appropriate treatment interventions given the range of preceding life problems. So as only 2/3 were assessed, it highlights room for improvement, particularly if we consider the barriers in service access that may be experienced by this group. Primary care can play an important role in assessment and detection of physical and mental health problems, which may enable earlier intervention and support a reduction in self-harm and future risk in this population. Penultimately, I'd like to outline some of the strengths and limitations of our study. Firstly, the findings are largely reflective of individuals who received a psychosocial assessment. So our understanding of those who were not seen is limited. Self-harm occurring in the community is not included within our data. Repeat self-harm was only identified if an individual presented to the same hospital. Some of the strengths are that our study used robust longitudinal data covering a 14-year period with data from 3 geographically spread study centres in England. Finally, more research in this area would be hugely beneficial, including exploring the longer-term outcomes following self-harm, as well as the link between self-harm and physical health problems in this group.
Thank you, Anita and Jenny, for laying out the foundation of the research so clearly for us. We've heard how self-harm in older adults is often under-recognised, even though vulnerability to suicide is significant, particularly when self-harm has been present. You've also touched on the range of life circumstances that can sit around distress in older age, from physical health challenges to social and emotional pressures. And we've begun to really hear how understanding someone's story through a psychosocial lens is key to supporting them safely and meaningfully. All of this opens up some really thoughtful questions about what this means for practice and how we meet older adults sensitively and compassionately. So with that in mind, we're now going to move into a conversation between Jenny and Anita, where they'll explore these themes in more depth and reflect on how the research connects to the realities we see in everyday work. Let's move into that discussion now.
So often we see self-harm discussed as a young person issue, don't we? But actually it's one that affects the whole life cycle. It affects all age groups. And what always strikes me when looking at self-harm in older adults specifically is although the number of older adults who self-harm is much lower than we see in other age groups, in other adult age groups, the consequences of that self-harm for older adults, the significant high risk of future self-harm and premature death is starkly different.
Yes, absolutely. We must take self-harm in this group seriously because of the high risk of suicide following self-harm in this population. So previous finding was that older adults who self-harmed were 67 times more likely to die from suicide than older adults in the general population. And given our study findings, which showed that self-harm rates increased by 34% between 2008 and 2016, greater focus in policy practice and research really is required for this group.
And then also generally when we talk about older adults in research and clinical practice, we're referring to all people over the age of 65 years, but that is such a broad population group, isn't it? And many people in that group may still be working, have active care or familiar responsibilities still, and not fall into that traditional retired definition that we hold in our heads. And it's that heterogeneity, that's what we found reflected in the study findings, wasn't it?
Yeah, so we really shouldn't be considering all older adults as one big group. We found key differences when comparing a younger and an older group within our older adult sample. So acknowledging the 40+ year period, which may be recognised as old age, really is important as it encapsulates a wide range of life events and transitions. Identifying these really is important for appropriate aftercare to meet an individual's needs and help keep them safe. Our findings also suggested differences between the younger and the older group in terms of help-seeking behaviours and barriers in service access, particularly mental health services for the older group. This may lead to a potential increase in demand for health services for mental and physical health needs following self-harm.
Yes, there were differences in terms of age or age group, but what about gender differences? We did see some key gender differences too, didn't we? But are there any clinical implications around that?
We did find some key differences, particularly in terms of access to mental health services between men and women. Men were less likely to have accessed or receive onward referral to these services compared with women. If we also consider the gender reversal of self-harm that occurs in older age, where self-harm rates are higher in older men compared with women of the same age, alongside the increase in self-harm rate that we saw for men in the younger group, it indicates that every contact with a health professional for men really is vital in terms of helping to reduce their self-harm and future suicide risk.
So yeah, and with that older age group, those 75 years and over, physical health problems were much more common, weren't they? And we know from previous research there's a really strong link between pain and self-harm. So although we didn't look at pain specifically in this study, it correlates very strongly with physical health challenges. And there's been a lot of large reviews and epidemiological studies that have shown that chronic pain in and of itself can double or triple the risk of future self-harm and dying by suicide. And that pain severity, duration of pain, and its interference with daily functioning can all increase risk. And then, of course, pain contributes to a sense of hopelessness, that loss of autonomy. It can disrupt sleep, sleep is so important in terms of maintaining good mental health. And then social withdrawal as well, all key mechanisms linked to suicidal behaviour generally. So any assessment following self-harm needs to comprehensively explore a person's current and expected future physical health and the consequences of that for their mental health. But this is the case for people of any age, not just older adults. Problems relating to physical health or pain across the whole life cycle. It's just that we're seeing that they're more common in this older adult age group. But then again, many older people experiencing physical health challenges don't go on to self-harm. So it really is about exploring what something means to an individual. And a successful psychosocial assessment seeks to understand a person's story, and that is what ultimately informs a clinician's formulation. So not the presence of a particular problem, life challenge, what we term risk factor, but what that actually means for the individual in that moment. And with physical health challenges, it could be a lack of hope of ever getting better, or perhaps a fear of increasing pain, reduced mobility, just general loss of sense of independence and what they're able to do and quality of life. So seeking to understand someone's beliefs, their experiences and perceptions of their situation and of their history gives us that idea of how challenges and risks can be mitigated against, and ultimately how we can make life safer for people in moments of crisis and when they're experiencing real moments of despair. And we know from other multi-centre work that something else that's incredibly important is that relationship with alcohol use, misuse. It's a really strong risk factor for future self-harm and for risk of suicide. But like self-harm generally, I think that tends to be discussed as in the context of working age adult, doesn't it? Not as an older adult issue.
Yeah, so we did find an association between problematic alcohol use and repeat self-harm in men over the age of 60. So slightly contrasting to it being discussed as a working age issue. But one explanation for this may be a cohort effect. So this is due to a rise in the rate of self-harm, which we previously saw in men in middle age, particularly after 2008. So some individuals presenting to hospital with self-harm will have transitioned from midlife to the older age group within our sample.
Yeah. So regardless of any age, really, it's really important that alcohol use be explored and addressed alongside any self-harm. And an attendance at the emergency department is a really valuable opportunity to validate a person's pain, to identify any ongoing alcohol misuse behaviour, even deliver brief interventions there and then within the emergency department. And then, of course, provide that link to ongoing treatment and support around alcohol misuse. Incorporating alcohol specialists into liaison psychiatry teams within the hospital is one way to ensure that services around this are prioritised and are safeguarded. And it also enables that holistic assessment, and those interventions are delivered quickly and effectively. So removing that challenge that a lot of patients share with us around having to repeatedly tell the same story to different individuals and different services. And also I've seen and heard about in many hospitals funding for alcohol services has been withdrawn, or services are in a constant battle to stay open. The provision of those services don't neatly align with the remit of either hospitals, so acute services, or mental health providers. And then obviously with funding for public health having been drastically reduced in real terms over the last decade, it can be a real challenge to safeguard that service for people experiencing challenges around alcohol misuse. But from a quality of care perspective, effectiveness, safetiness perspective, alcohol services based within the hospital setting and being really closely aligned or indeed integrated with liaison psychiatry services is an absolute non-negotiable. So then moving on and thinking about more generally what helps support people following presenting with self-harm to the emergency department. That provision of a timely psychosocial assessment is really important, isn't it? And we know that from previous research from the Multicentre Study itself, but also other pieces of work. They can serve as a protective factor from future self-harm and suicide. And some of our previous Multicentre studies have found that risk can be reduced by up to 50%. So unfortunately, we know that looking at service data up and down the country nationally, only around 60 to 70% of people coming into the emergency department with self-harm actually receive a psychosocial assessment.
Yeah, so we also found a relatively low level of older adults received a psychosocial assessment, around 2/3. So for us, this was concerning given the high risk of suicide associated with self-harm in older age. Possible reasons for the low rate of assessment may be that individuals left the emergency department before an assessment was completed, or there was high clinical demand within emergency departments versus the amount of clinical capacity available to meet such demand. In terms of the management of self-harm in older age, NICE guidance does recommend assessment by a mental health specialist, covering a range of factors, including cognitive impairment and physical illness. Given that there may be fewer opportunities to intervene with this population, assessment really is a vital gateway to understanding the needs of the individual and for identifying appropriate aftercare.
So in terms of aftercare then, thinking about older adults, what do the findings of this paper suggest may be most commonly needed by this group?
So given the range of life problems which were identified that preceded self-harm, we believe that interventions beyond medication should be explored, such as relationship counselling, financial advice and alcohol use support. Additionally, closer partnership working with voluntary agencies alongside social prescribing would help provide alternative support for mental and physical well-being, and also in terms of reducing loneliness. So clear communication between primary and secondary care services, mental health services can be supported by the all-important psychosocial assessment and subsequent safety plan. This can enable greater collaboration in delivering the aftercare that really supports an individual's treatment journey. And what our findings also showed was challenges with service access and reduced help seeking with this group. So earlier intervention really is required. And given the strong link between physical and mental health problems, primary care services can play an important role in identifying and managing risk by improving assessment and treatment of both mental and physical health problems, such as chronic illness and pain.
Yeah, so wherever we're meeting with that individual, and whether it is primary care within an emergency department setting, it's taking that holistic biopsychosocial approach, exploring what recent events or challenges mean for that individual in that moment, and then that real close partnership working across physical and mental health care, bringing in voluntary sector and social care that can make a real difference for somebody. Thinking about where our gaps in knowledge are around self-harm and older age, where should we be looking next in terms of research?
So I think we need to consider what it means to be an older adult and what changes occur in older age. This will help add depth to our knowledge and understanding of self-harm in older adults. And given that older adults are underrepresented within self-harm research relative to other age groups, more quality research is generally needed. But as well as considering older age, looking at the whole life cycle, which culminates in older age, is important. This may include looking at the multiple socio-environmental factors which are relevant in our earlier years, as well as older age, but are also important in preventing both self-harm and suicide. In terms of exploring longer-term outcomes from self-harm, future research looking at suicide and other causes of mortality is needed. But yes, definitely more focus is needed, given the observed increase in self-harm rates that we found in our study, as well as growth in the UK older adult population, which is projected in the years to come. More focus really is required in research, policy and practice.
Okay, so thinking about what the key takeaway messages for this work, from this work might be then. So problems around physical health and alcohol are particularly common in the older age group, and we know that that older age group has an elevated level of risk. There are some gender and age differences within the cohort, like with many others. But as with all people experiencing self-harm, in order to truly help, we need to explore what issues and challenges in life and events mean for an individual in that moment, in order to be able to identify what might be of help to them and how to increase their safety. So when someone attends the emergency department with self-harm, or indeed any clinical service or non-clinical service, it's a really important opportunity to validate somebody's distress, make them feel seen and heard, and then help them identify what could alleviate some of that distress in the immediate and then the long-term future.
Thank you, Jenny and Anita. What an informative and engaging conversation. Thank you so much for sharing with us. I guess the takeaways for me are that if we genuinely want to help older people, we need to understand what their challenges mean to them, to the person in front of us. Especially in later life, where changes in health, identity, and connection really hit differently. We know that contact with services is a real moment of opportunity. Every contact can help to prevent suicide and self-harm. We need to make sure older people feel seen, validated, and not brushed aside. If we are seeing self-harm in those people over 70, we need to take that very seriously. And importantly, and I guess especially for the work we do at Storm Skills Training, a high quality psychosocial assessment really works. It helps people to feel understood, and it can help to reduce repeated self-harm by up to 50%. It strengthens safety in the moment, immediately after, and over time as well. Again, thank you to our colleagues at the Multicentre Study of Self-harm in England, and to you, Anita and Jenny. One area that was highlighted today was around alcohol use and suicide in the older population. We look forward to hearing more about alcohol and suicide across the lifespan in a future webinar. We hope to see you watching then. Thank you and goodbye.